Okay, good morning, everyone. Welcome to Wednesday morning rounds. Before we get started today, a couple housekeeping issues. If you're attending rounds in person, please sign up in the sign-in sheets at the back of the room. Otherwise, we don't have any way to track your attendance. For those of you attending rounds virtually, when you register for rounds and log in, that is how we track your attendance. In January, by the end of the second week of January, we will be distributing your letters for rounds attendance. That will give you the number of hours that you can claim for CME. It is your responsibility to log those numbers into your main port account on the Royal College site for your continuing medical education credits. So those are not logged by us. That is your responsibility to log in. The deadline for submitting your credits to the Royal College for CME for the 2023 academic year is January 31st. So you will have several weeks time once you get that letter to get your credits in. This is the last rounds for this academic year, so I'm wishing everyone a happy holiday season and hope you all take a break. I'm sure everyone needs one. Rounds will resume in the new year on January the 10th. That will be a grand rounds event organized by Research Services. You should have received an invite to sign up for those rounds. It'll be Dr. Eichelboom from McMaster University, who's well known in the cardiovascular world. He will be attending in person, so please try and come in person if you can. It's always nice for visiting speakers to have an in-person audience to speak to. Other than that, that's all the announcements. We're going to move on with rounds today. It is my pleasure to introduce one of our PGY6 residents, Dr. Mohammed Abalhassan. He's going to speak today to us on the PFO and is it innocent or guilty? So welcome.
Good morning, everyone. Thanks, Dr. Stadnik, for the introduction. Thanks to everyone for attending virtually or in person. It's a pleasure to be here, and it's a great pleasure to present about PFO. Reason I chose this topic is I recently got involved in a research project looking into PFO closures in an elderly population. And when I looked back into the data, most of the trials actually included those patients younger than 60 years of age. So we'll dive into the data and we'll see what the literature mentioned so far. So a brief introduction about PFO. So it's a common findings that presents in about 25% of the general population. It serves as a small opening between the right and the left atrium, and it can predispose to passage of blood clots or embolization of gases into the left system, and that can embolize anywhere in the body. More specifically, with devastating outcomes if it's a stroke. That can be managed either percutaneously or medically with antithrombotic medications. And there has been lots of debates of whether to close the PFO and when to close it and when do we call it it's significant. I'll start with a case of a 53-year-old gentleman with no past medical illness, sustained a documented stroke with no residual weakness. This patient's referred from neurology for consideration and workup of cardiac source, namely PFO. Thrombophilia workup was negative, and there was significant bubble studies with right to left shunt. And the question is, do we close that PFO or do we anticoagulate or should we just use antiplatelets? There has been multiple guidelines, more recently the SKY recommendations. There's the Canadian stroke best practice that was updated in 2020, the European position statement, and there is an American Academy of Neurology recommendations. The major trials that looked into PFO closure involved patients less than 60, between 16 and 60. Most of the trials compared closure to antithrombotic, namely antiplatelets. The only trial is close to involve one arm of anticoagulation. They also all looked into stroke. The only one looked into TIA was the REDUCE trial. And all of the trials actually showed significant difference between closure as opposed to medical therapy alone. So when we look into the Canadian stroke best practice, it was updated in 2020. So the recommendation is those patients should be between age 18 and 60. They have to be assessed for stroke by an expert in like a neurologist, and it has to be non-lacunar embolic ischemic stroke or TIA with positive neuroimaging. They actually they said reasonable to recommend against closure if you do not have high risk features. And in those patients who needs anticoagulation, probably reasonable not to close and go ahead with anticoagulation. The American Academy of Neurology asked two important questions. The first question, whether closure of PFO in cryptogenic stroke reduce the risk of stroke recurrence compared to medical therapy alone. The other question is whether anticoagulation compared to antiplatelet agents. They involved multiple trials, extensive review of the literature, and the fixed effect meta-analysis actually showed an absolute risk reduction of 3.4% with PFO closures compared to medical therapy, with some risk of periprocedural atrial fibrillation. When they compared anticoagulation with antiplatelets, the random effect meta-analysis showed equally effective between both arms. That also included trials like Respect ESUS, Navigate ESUS. Those are large trials, and it also involved patients who are on DOAC because most of the recommendations were on oral anticoagulation with warfarin. They came up with 3 statements. So the first statements included that the patient should have thorough evaluation, obtain neuroimaging, vascular imaging as well, and a baseline ECG to rule out atrial fibrillation. Those patients with high risk of atrial fibrillation need to undergo prolonged cardiac monitoring for atrial fibrillation for at least 28 days. So to start with a transthoracic echo and followed by a transesophageal echo, hypercoagulable workup studies should be done, transcranial Doppler saline contrast for screening evaluation, and those patients should be assessed by clinicians with expertise in stroke. And we should look for alternative mechanism of stroke before recommending PFO closure. The second statement, they looked into, they said a patient with age younger than 60 with an embolic appearing infarct and no other mechanism identified may recommend closure. The presence of large shunt is associated with benefit from closure, may be offered closure for populations such as for patients 60 to 65 when there is limited degree of traditional cardiovascular risk factors, and may be offered for those who are young, who does have small deep stroke with a large shunt. So it's an individual decision making on these patients, and always shared decision making with the patient because there's no guarantee that the stroke would be recurrent or not. And if the patient received medical therapy alone without PFO closure, may recommend antiplatelet or anticoagulation. And if they're already on anticoagulation, the patient should be counseled that PFO closure in addition to anticoagulation cannot be confirmed or refuted. The European position statement was published in 2021. They're based off limited and observational or low quality certainty randomized data. They did not, these are not guidelines to follow. They're more in different clinical settings. They're very, the paper is very robust, and they involved in the supplement publication covers multiple facets of situations of when to consider PFO closure, in decompression sickness, desaturation syndrome, in migraine, in neurosurgery, and sitting position. When there's a left circulation thromboembolism, to start with a transthoracic, so they agreed with or transcranial Doppler followed by a transesophageal echo. It also advocates when a PFO is considered to play a pathogenic role in embolism, the episode should no longer be called cryptogenic stroke. Sometimes it's difficult to rule out other potential causes, but there's risk scores to calculate and risk stratify these patients. There's one score called the ROPE score, which there's cardiovascular risk factors. Whenever there's risk factors, the higher the score, the lower the score. And the younger the patient is, the higher the score, the likelihood the stroke is related to PFO. And then the Pascal score, which is interesting, it actually incorporates ROPE score as part of it. So it involves ROPE score more than 7 and above, and then it'll take into consideration the features of PFO. If there's a large shunt, atrial septal aneurysm, and then based off these findings, it'll deem this PFO-related stroke is unlikely, possible, or probable. This is also from the European Position Statement, percutaneous PFO closure versus medical therapy for secondary prevention. If this is high risk, then PFO closure, but if low risk, then maybe medical therapy alone. But it is justified if the patient had a stroke, likely to be PFO related in the context of an antithrombotic therapy with antiplatelet or anticoagulation, may be reasonable to go ahead and close it. And then they talked about secondary prevention with oral anticoagulation versus antiplatelet. So long-term oral anticoagulation, that's if there is low hemorrhagic risk, good therapeutic compliance, and there is monitoring, sure, anticoagulation. But if the above is not satisfied, then antiplatelets. And there's no position can be expressed on DOAC, but it has been there for a couple of randomized clinical trials. What about duration of therapy post-PFO closure? So the European position statements recommended reasonable to propose dual antiplatelet therapy for 1 to 6 months after PFO closure, and then single antiplatelet therapy to be continued for at least 5 years. And those patients should be should have antibiotic for prophylaxis for endocarditis. Then the SKY guidelines came in 2022. It is a little bit different, but we'll go through that. So if there's a PFO with no prior stroke, it suggests against closure. And if there is platypnea, orthodoxia syndrome, systemic embolism, then suggests PFO closure. But when there is a prior stroke, closure versus antiplatelets, the recommendation, if the age falls into the category that has been discussed in the guidelines, in the trials, then with a high ROPE score, high risk anatomy, then closure plus antiplatelet. If they are 60 and older, thrombophilia on antiplatelet, then conditional recommendation for PFO closure. If the patient has atrial fibrillation, they recommend against closure, and there's no recommendation when patient have remote stroke. In PFO, the same thing with prior stroke. If the patient had DVT, thrombophilia, PE, still conditional recommendation of closure with anticoagulation. Post-closure management is a little bit different from what the European position statements. They actually recommended dual antiplatelet therapy for 1 month, followed by aspirin for only 5 months. So again, these guidelines are to help clinicians, but they don't serve as a standard of care, and it actually describes knowledge gaps to be filled by future research, and the decision must be made on the unique circumstances of each individual patient. But the argument is always if the risk of the procedure, a PFO closure, is relatively low and there's a definite association, then why not to fix them all? But the counter argument is that doesn't mean it's the cause. And looking back into the literature, there's competing causes of stroke in more than 50% of cases where other potential embolic sources were identified. So if PFO is not the only culprit mechanism, probably look for something else. So then probably when assessing a patient with PFO and stroke, the rules are go through the story. So if the event happened during Valsalva or an extended travel, surgery, history of thromboembolism before or within 72 hours of the index stroke, history or lab evidence of thrombophilia, factor V latent antiphospholipid syndrome, or if there's clinical disease well known to increase the shunt from right to left. Rule number 2, describe the risk factors for this patient. Those patients sometimes have atrial fibrillation that's not diagnosed clinically. And so the older they are, the natural history of atrial fibrillation is that they are predisposed to atrial fibrillation with age. Vascular risk factors increases their risk of atrial fibrillation. And if they have a previously established lacunar stroke, that is less likely to be an embolic PFO related. And then rule number 3, establish its embolic. This would be the help of expertise of our colleague neurologist. So stroke with embolic features, clinically or on neuroimaging, is likely to be related to a cardioembolic source. This is a study involved 2,500 patients. The larger and the more superficial is the likely related to PFO. And the more it's recurrent, it is less likely related to PFO. This is just an illustration of how it looks like. The lacunar stroke is more central, more small. This is on MRI on the top. And this is how it looks like when it's embolic. It's more superficial, more large as compared to the ones on the left. Rule number 4 is clear the vessels. All patients who we suspect PFO-related stroke should undergo, and I think that's the standard of practice. So CTA or MRA is a must to identify the vessels. There's lots of information that can be obtained when doing that. So if there is a carotid artery stenosis of 50-60% or intracranial atherosclerotic disease, this is a high probability that this is not related to PFO. If you have someone with dissection or fibromuscular dystrophy, again, these patients can have stroke in young age, so that has to be ruled out. In patients, this is interesting, in arch atheroma or plaque, usually lacunar stroke in atheroma, and non-stenotic plaque. If you find them, yes, you are worried, but you cannot be definite. It is the culprit. Only plaque with high-risk features, such as lipid-rich ulceration, accounts for, in one study, that was a systematic review, meta-analysis, there's only 32% a patient who had a carotid plaque with high-risk features had stroke. Rule number 5 is clear the heart. Paroxysmal atrial fibrillation, tumor, atrial cardiopathy, or valvular lesion that can predispose to clot formation. There's an interesting study that was from 2023. It looked at the patients involved, the mean age of 48, so relatively young. Only 50% has isolated PFO with stroke, and the others had other potential embolic sources. And another study looked into, this is the Navigate ESAS. Not surprising, the mean age was 67. In older age, the patient also had other risk factors. So the higher number, the higher the potential embolic source. Rule number 6, now we cleared the heart, we found the PFO. Now you have to characterize the PFO. Is it large size? Is there presence of atrial septal aneurysm? Is the septum is hypermobile with Valsalva? How large is the PFO? And if there is a septal excursion more than 10 millimeter on echo. This is something I find interesting. I've only seen this once when I was on consult services, but this is published in Circulation. It's in 2003, but basically the anatomy of the SVCs, superior vena cava and IVC, in relation to the foramen premium and patent foramen ovale is interesting. So if you have a suspicion that there is a PFO-related stroke with a negative bubble study, but in a younger population where no other things identified, you may consider an IVC bubble study because the eustachian valve lies below the SVC and the IVC is below it. So a bubble study through IVC will increase sensitivity and specificity because the jet goes against the foramen premium. And as illustrated here, this is a bubble study. And as you can see, you can see the flow from the IVC competing the bubble studies coming from the SVC. What about atrial fibrillation post-PFO? Something we need to consider when counseling our patients for PFO closure. It is commonly reported mostly in the first few weeks after PFO closure. Some studies suggested only 45 days. There's different practice. There is no guidelines or recommendations of how do we treat that. Some practice, some clinicians will keep their patients on beta blockers in the first few weeks. Some put antiarrhythmic, some empirically anticoagulate. So there's no guidelines, but we know that age is found to be significant interacting factors. This is well established in the natural history of AFib in the general population. The proposed mechanism is this could be catheter manipulation when crossing into the left atrium and can trigger atrial fibrillation. The other mechanism would be creating a macro reentrant circuit, and it has been linked to different devices than other devices. So I did not bring the data on which devices. This is not the scope of the talk, but there has been specific devices has been described to have more atrial fibrillation post-closure compared to other devices. Evidence. So this is a reduced study. It was published in 2017. This is one of the large trials for PFO closure. There's 6.6% atrial fibrillation post-PFO closure compared to medical therapy, statistically significant in the first 45 days period post-PFO closure. The other study is CLOSE, also published in 2017 in New England Journal of Medicine. Atrial fibrillation was also in 4.6% as compared to the other group. Another meta-analysis looked into 32 studies. Six of them were randomized clinical trials. Other 26 was observational case series and small studies. And there is 5 times risk increase in atrial fibrillation compared to medical therapy, and it's highest in the first 45 days after PFO closure. Another database that's an Ontario administrative health data on the incidence of new atrial fibrillation post-catheter closure of PFO. They reported it as was relatively low, but having diabetes or age more than 60 were the most important factor associated with new onset, not surprisingly. We clearly need more data. There's no studies with prolonged monitoring for these patients. This is interesting. This is a French study. It is finishing in 2025 that we're waiting for. It finished recruitment in 2023. They actually implanted loop recorders for these patients 2 months before PFO closure. And they followed these patients. They're going to follow these patients up to 2 years. So we will definitely have more data if there's other risk factors like atrial fibrillation, pre-closure, and what are the risks post-PFO closure. So the bottom line is screening in general for all patients. Those with high risk need prolonged monitoring, especially if they have other cardiovascular risk factors. They suspect the more you look into it, the more you will catch before a closure decision. What about elderly patients? This is what triggered looking into this data. So most trials address those patients less than 60, and most guidelines suggested weak recommendations for patients more than 60 years of age. The evidence of recurrent stroke or cerebrovascular events with PFO more than 6, there's evidence, and the age group is more complex. So yes, there may be benefit to those patients, but we should select those patients carefully because there may be other potential sources. This is the design that this is a study that we collaborated with. It involved 14 university centers, international study between 2000 and 2023 with a follow-up of 2 years. The patients involved were above the age of 60 who had PFO, ESUS, high rope score, and other potential causes for the thromboembolic event were excluded. We're looking into mortality, new recurrent thromboembolic event, such as ischemic stroke, TIA, new onset atrial fibrillation, DVT, myocardial infarction, and we're looking into also leading events. If you look at the rope score and the Pascal classification system, if you have someone who is more than the age of 60 with no other risk factors, the rope score would be low. So if you look into the Pascal, those patients with gray zone maybe use the Pascal system because at least they can fall into a possible PFO related stroke. So yes, these patients may have other risk factors for stroke, but they may have this as the only reason for causing their stroke. So I think we should look into this further. More research is needed to better select these patients. Special population. This is from the European position statement and patients with decompression sickness. So the recommendation is to counsel these patients. Now, these patients may have this as a hobby or it could be a job that they're doing. So counseling these patients, consultation with expertise in dive medicine is recommended. If they're not willing to quit, then consideration for PFO closure is reasonable for secondary prevention, but always start with counseling the patient. What about the data on migraine? So it is only refractory to medical management. There's a lot of emerging treatment for migraine, but only treat migraine with conventional therapies. Consider PFO closure only in clinical trials or for compassionate use in migraine with aura. This started actually with a Lancet publication in 2000 when they saw these patients who had PFO closure for stroke indications. 48% have resolved their migraine and 38% had improved in their migraine severity and frequency. Following that, there's 4 studies came after, which did show benefit from closure, but it was not statistically significant until this meta-analysis got published in JACC in 2021. And if you look at the right bottom figure there, 9% of patients who had PFO closure abolished their symptoms for migraine. So there is something that, but it's not something we've been, there's evidence, but it's not something we've been commonly closing PFO for because again, there's also risks post-closure. Arterial deoxygenation and PFO. If there's a patient with platypnea orthodeoxia, first to rule out other causes for this, because there are potential cardiac or pulmonary causes for that. But if PFO is thought to be the main driver for that, then PFO closure is recommended for these patients. This is interesting. I actually didn't know that until I was looking into the data for neurosurgical procedure in the sitting position. This comes from the European Physician Statement. They routinely screen patients who was going for neurosurgical procedure in the sitting position. PFO closure is reasonable, followed by neurosurgery at a later date. Those for elective cases, obviously. But they stated in patients with PFO, neurosurgery in sitting position is contraindicated. I haven't come across that before, and it's something that I just noticed. This is from 1999, but it is in the European Position Statement. The last 2 or 3 slides, in patients who have hypercoagulable state, this is a JACC publication from 2020. They looked into event-free probability with PFO closure without thrombophilia. Those who had PFO closure with thrombophilia, I don't know if it's clear on the screen, but those who had PFO closure with thrombophilia, this is in the yellow or orange, did better compared to those who had medical therapy with thrombophilia. So clearly, even those patients with thrombophilia on anticoagulation still would benefit from PFO closure. This is also very interesting. This is a study from China, involved 530 patients. The question is always, if we have PFO, like, should we anticipate or should we wait for patient to stroke and then look into the PFO? This actually looked into in situ PFO thrombi, and it was detected in 83% who had stroke, 57% had migraine, and 0% on those patients who are asymptomatic. And they used an OCT, optical coherent tomography, to look into that, and they identified the thrombi within the PFO. So interesting, more data needed, more research. And there's another JACC publication looked at the characteristics of PFO in patients with and without stroke. And this is in JAMA 2021. And 100% of those patients with significant p-value, those who had stroke, there were in situ thrombus within the PFO. So clearly, we need more data on that. We need a multidisciplinary team approach, a discussion, especially with our colleagues, neurologists. And we would love to know and to clarify, when we get referral for PFO closure, does that mean we look into anatomical feasibility for closure versus looking also into potential sources of embolization and further workup? Special population, divers needs to be in consultation with diver experts. Those who are pregnant, mode of delivery, if they have PFO with high-risk features, should we involve cardio-obstetric in that situation? The special population, those who are more than the age of 60, not included in the clinical trials, those all need more careful discussion. And again, shared decision making with the patient. With that, I conclude. I would like to thank Dr. Labanaz, Dr. Hibbert, Dr. Abdelrazak for their support throughout this project and presentation, as well as Dr. Rodis Kabou and Farjet Passus from Quebec Heart and Lung Institute for allowing the opportunity to collaborate, and we look forward to collaborate further in future research. With that, I conclude, and thank you so much.
Thank you, Mo. I think there's a question. Someone raised a hand on MS Teams. If you can answer that. If you have any questions, you can raise your hand and ask, and we'll unmute your mic, or you can type it in the chat. Dr. Liu, I think you have a question. Go ahead.
Yeah, great presentation and on clinical services. So I really also encountered these type of situations as well. So one is that fully endorse the concept of a multidisciplinary team. Because this is an area which we discussed. Really would benefit from the collaboration of cardiologists and neurologists as well. I have a question that is that when you do have a PFO that is maybe accounting for the stroke, should one nevertheless look for coagulation abnormalities, because it's a multifactorial type of setting, so what threshold will one consider, look for, factor Leiden or whatever other, potential predisposing factors, when you see stroke in young patients?
Yeah, thanks, Dr. Liu, for the question. Yeah, so all of the recommendations from the guidelines would highly recommend getting a thrombophilia workup in all patients, even the young patients where other potential embolic source is not suspicious. So those investigations needs to be negative before consideration of PFO closure. And I was just speaking with Dr. Labanaz about one of the patients who recently referred for PFO closure, who had a factor V Leiden that was positive. So that patient will end up being on anticoagulation and not necessarily PFO closure.
Great, thank you.
Thanks.
I think Dr. Beanlands has a question.
Actually, I was going to highlight Dr. Dalawachi's trial, but I see that he's actually managed to get online. He had some trouble getting on, so maybe I'll just hand it over to Dar, who I think is next on the question list online.
Thanks, Rob. It's Dar Dalawachi here. Great presentation, and then thanks for the updated information. Yeah, I wasn't just going to plug my trial, although I'm happy to do that. Thank you, Dr. Beanlands. But before we do that, I just want to make a comment. So I'm a big believer in PFO closure in the ESUS population for cryptogenic stroke, and as highlighted by Dr. Liu's question and some of the data you showed, I guess you have to ask yourself, for those cardiologists and family docs who have referred for PFO closure in the context of quote unquote stroke, how many of them have actually done a brain MRI, APLA testing, full thrombophilia screen, cancer screening, and full lumen vessel imaging? And I'm going to include, shockingly, neurologists in that population. I'll say that when the stroke clinic refers you guys PFO closure, we've done all that. So there's a subset of patients that come to us by our colleagues. So our own colleagues will send them, as well as community physicians. And it takes us about 8 weeks to 3 months, to sometimes longer, to properly diagnose a patient with ESUS cryptogenic. So that's the real evidence-based patient for PFO closure. But I am well aware that there's a subset being referred to directly that don't go through us, including from neurologists. And you made a very important comment where you said, is our role just to check the anatomy and close it, or is our role to also see if there's an indication? And that's the trick. So the stroke clinic is always there for you. I know Dr. Labanaz and others have always referred to us and I remember quite a few coming from Hibbert saying, are you sure we should close this? And I'm going to give you 2 very recent examples in the last 2 months. One was a patient referred for closure and was closed by a attending physician neurologist from NLA, not a stroke doctor, who had a carotid web with a thrombus sitting on the carotid web. So we call that a obvious smoking gun. And rather than address the carotid web, they found the PFO and referred for PFO closure. The patient had a major stroke 3 months after PFO closure from a very large carotid thrombus. And another one was a patient very, very astutely referred back to me by Dr. Hibbert, because they were referred for PFO closure after they had a cerebral hemorrhage, and somebody found a PFO on the echo. This was referred also by a neurologist for PFO closure. So sometimes I think what's happening are people falling into this ABC issues-based type trap. They see a PFO in a patient with a cerebral event and they refer. So please use us as your gatekeeper to look through these patients for you. The trial that Dr. Beanlands referred to is what we call incognito. It's under the BHI, the brain and the brain heart interconnectome. And we are taking cryptogenic strokes. So myself, Deb Siegler, the co-PIs, Kevin Boxar is on this study, Ian Patterson is on the study, so is Dr. Beanlands. And we will take your suspected cryptogenics, and as a clinical workup, we will clinically take them all on and do a full cryptogenic workup. And once we establish a real cryptogenic diagnosis, we will randomize them, even if they have a PFO, into a cancer screening, intensive cancer screening with full body PET scan versus routine cancer screening, in addition to cardiac and aortic MRI done by Dr. Patterson in both arms. And the idea here is, even if they have a PFO, and we allow, of course, PFO closure per standard of care, so they go on the usual path, that subset that you talked about where they get their PFO closed, but they have another condition, like maybe a thrombophilia, and maybe PFO closure still helps them on top of that. That's what we're addressing. We're saying, even if the PFO was the conduit for paradoxical embolism or even in situ embolism, it's possible the patient has something else. And that's what we're trying to address. So if you do think you have a cryptogenic stroke, all you got to do is refer them to the stroke clinic. We take care of the rest. Thanks.
Thanks so much for your comments. Very, for sure, something to utilize as a source, and definitely will collaborate with that.
Dr. Beanlands, did you have another comment? Your hand is up.
Yeah, just very briefly, Mohammed, great rounds. Thank you so much. Very comprehensive and getting us up to date on the problem. Just to kind of tag on to what Peter and Dar were mentioning, that I think that this is a way and a path for collaboration, and it may be a reasonable thing to build on to develop sort of a brain heart team around decisions for these patients, because as you pointed out, Mohammed, it's not always easy. Also, we can support the research that's ongoing. So great work. Thank you again.
Thank you.
I think Dr. Malloy has a comment or question.
Thank you, Mohammed. That was a great talk. Just because you mentioned it, a quick comment on decompression sickness and PFO closure. So the literature kind of mirrors that in stroke, which is to say that it's probably a very small minority of all patients with decompression syndrome who have a PFO who should go on to have a PFO closure and continue to dive. And the conversation is equally as nuanced in terms of, are there other mechanisms by which this could have happened? Are there other ways that we might prevent this from happening again in the future? And there's certainly things that can indicate that a PFO was the mechanism of decompression sickness. What we might call a non-provocative dive, specific types of decompression sickness. So cutis marmorata, neurologic DCS, inner ear DCS are all more closely associated with PFOs. But there is literature to suggest that conservative dive profiles in patients with small PFOs are every bit as good as PFO closure. So it's really only in the patients with large PFOs, unexplained, unprovoked, as much as that term is useful, decompression sickness, who must continue diving for their career, where PFO closure should ever even be considered. And so I think you were right to point out, in the European position statement is correct to say that most of these patients should be referred to either a cardiologist with an interest in diving or a dive medicine specialist, or somebody who's both, if you happen to have that in your center, before considering PFO closure. It should not be the standard of care for most of these patients.
Thanks, Dr. Malloy.
Dr. Chan?
I think that there's an intrinsic limitation in the score system, the how you classify it, particularly when you use age, right? Because the frequency, the preference of PFO is age dependent. So if I see this as an intrinsic limitation in the rope score, where you use 18, you say, wow, I give a high number. You take 18 years old, 1 in 3 with a PFO, right? So there is this intrinsic weakness, and I think in this scoring system that we have to be mindful of.
Yeah, thanks, Dr. Chen. And that's where the Pascal score can also play a role in that gray zone areas when age can alter the scoring classification of patients.
Dr. Laminez?
Mohammed, great talk, good overview. The majority of patients that come, just to answer some of the other questions, that the patients that come to me now have come through neurology. So the usual workup is they've been seen by the stroke neurologist because they've come in with stroke. They'll have their brain imaging, usually MRI, always CTAs. They'll have a thrombophilia workup. Sometimes, because of cracks in the system, like this patient I'm seeing tomorrow, the workup was ordered when they was seen by the neurologist, but the result just came back a month or two ago. So, I'm going to tell them to have factor 5 tomorrow. And then they all have 14-day Holter monitors, right? And so, that's the usual workup. And in fact, if they get sent to me by other people, without having seen a neurologist, I always send them back. I actually tell them I'm not going to make that decision. They go back to a neurologist for that workup to get it done. But Dar, to answer your question, if somebody comes to me from a neurologist, I would assume that they would have determined that they think that the PFO was causative and are asking me as a cardiologist to close the PFO. And I think that should be spread among, I don't know if any other neurologists are on that talk, but I really would like to emphasize that, I defer to your expertise. I'm not a neurologist, so I'll provide the technical and sort of cognitive aspects towards closing the hole. And, I'll always calculate a rope score to make sure it's plausible in my mind. But, if a neurologist sends me a patient for PFO closure, I assume that they think that's the cause, and I'm not going to veto a neurologist's opinion. Now, if that's not true across all neurologists, then, I would ask you, to maybe discuss that at your division meeting to kind of get that sorted out, because Omar's coming in July, and I think he behaves the same way. Non-neurologist referrals, we always send back to you guys for assessment.
I totally hear you, and it's one of those uncomfortable diplomatic things. So there are neurologists in the community that at least a couple that have rolled into town that I've never even heard of. So there's that, and that means they could be excellent or they could have limited training in stroke. I really don't know. So that's a problem. I'm sure not unique to our specialty. Most of them, I'd say 95% of them, we know them. And there are, I mean, I hate to say it, but again, I don't think unique to our specialty, some that are really good in some subspecialties and not in others. And I get it. I don't know. I don't think Ben's here, and he probably shouldn't comment if he is, but Ben has sent myself and a couple of my colleagues emails every now and then saying, I received this from such and such. Should I proceed? And I know how bad that is, and yes, we do try and discuss it at our division meetings, and we certainly, I'm an NBU neurologist on a stroke unit, and we talk about it ad nauseum on the stroke unit of bystander PFOs, and stop even documenting it in the chart when it has nothing to do with the patient. But you guys know, like, people just rotate through, and they see a test result and they heard of a thing, they put it in the chart, and then this cut and paste in the chart goes on, and then the next thing you know, you get this discharge to some doctor that says PFO, and then off it goes. So I again, no different than any other specialty. I think sometimes it's reasonable to send an email if you're uncertain. 95% of the time, your neurologist has probably already talked to another neurologist, and it's a legit referral. But if you get a funny feeling, that something's not right. Why am I being referred in a 70-year-old for PFO closure and it's not from the stroke clinic? Probably it's reasonable to just fire off an email for a quick check. And especially, you know what, you can use the trial. Again, I'm not trying to pimp my trial here, but you can use the trial to say, hey, you know, I got this PFO referral out from this community neurologist. Should this be, you know, looked at for your trial? And I can take it because as part of when I get those all the time, by the way, because people are referring for the trial. And the first step is I check if there's been a cryptogenic workup. That's the first step for entry into the trial. So I can say, you know, this patient hasn't had a cryptogenic workup. That might be a diplomatic way to head that off for you.
Does anyone have any other questions, either online or in the room? Okay, I have one question. I think Mo, in your your slides comment about guideline papers or statements. It's to screen for 28 days for AFib. I think our halters are 14 days. So are we doing 2 sequential 14-day halters? Are we sticking with 14 days? What's sort of the general practice?
Yeah, so I think they don't still, those are not, they, especially the European position statement, it's based off observational data. And the practice is 14 days. I think that's the longer we have. But if the patient is considered high risk, then prolonged monitoring is recommended. And that's what we do when we think based off the echo, left atrial size, the story. But the standard of practice we do is 14 days. The recommendation is 28 days, but again, the evidence is not really strong, it's weak. And those with higher risk, those usually we would do prolonged monitoring for those patients.
Okay, that's great. Thank you so much for your presentation. Does anyone else have any other comments? Okay, well, that brings us to the end then. Please sign up in the sign-in sheets to get credit for your attendance, or if you're online, we know you're here. Have a good holiday, and you will receive your CME letters mid-January for you to input that data into your Royal College main port for your CME maintenance and certification data. So have a good holiday, everyone, and we'll see you in the new year.
Thanks, Ellie, and happy holidays, everybody.
Thanks, Dr. Shannon.